Okay, this is questions around evidence around airway management. So, Simon, take me through some conditions where you would maybe need to start thinking about how you manage the airway.
So, returning to a patient who's reported as unconscious, my initial assessment will be following the CABCDE approach. First thing I'm going to assess to see for any damages to myself, my colleagues, the patient or the public. And then I'm going to be assessing for any evidence of a catastrophic bleed.
Right.
Following a stepwise approach and correcting that. And then I'm going to be assessing the airway, so I'm going to be looking, listening and feeling the patient for 10 seconds to see if there's any rise and fall of the chest. Well, we're looking to make any respiratory effort at all. And in this particular case, the patient's not making any, there's no rise and fall of the chest. So visually, I'm going to use a head tilt chin lift just to open up that airway.
Okay.
And again, I'm going to be visually inspecting the airway to see if there's anything including the airway that I can see. And we then move forward on a stepwise approach. If I can see something including the airway, for example, there's vomit in place, I'm going to be looking at using a manual drainage, so I'm going to be looking to rotate the patient, tilt the patient over onto the side to allow for natural drainage, and then move the patient back, again opening up the airway and see if that then starts a respiratory effort within the patient. Again, further visualise the airway for any occlusions that I can see.
Okay. So what if this was a trauma patient or you had a significant suspicion of spinal injury? What technique would you use instead of head tilt chin lift?
So we're looking to use a suction in that particular case. So we use a automatic suction device, the lateral suction device.
Okay.
So we're looking to use that with a minimum amount of suction, no more than 10 seconds at a time, to clear the obstruction within the airway.
But sort of more specifically, obviously you would maybe not consider head tilt chin lift. What would you consider instead?
So there's also the option for a log roll of the patient as well,
Yeah.
maintaining the C-spine.
Okay.
And potential there for using support with the neck, i.e. a neck brace.
So, but what about a technique to open the airway?
So
it's not head tilt chin lift.
So the other is a jaw thrust, in which case we'll be looking to perform this maneuver to open up the airway.
That's all. Open the airway. This is
Not
all
opening off the table.
That's fine. Okay. So a jaw thrust. Once that's obviously different from a head tilt chin lift.
Yeah.
Because you can't sort of just maintain a patient in a jaw thrust. You have to keep applying that positive pressure.
Yeah.
But as you said, there'd be suction. What else if there was things that you could see, including the airway, that you couldn't necessarily remove by suction? What other or by postural drainage, like foreign bodies in the airway?
So if I can see, when I'm visualising the airway, if I can see there's an occlusion, for example, a piece of food or something, within view, I can look at using McGill's forceps to remove
Excellent.
that.
Yeah, that's perfect. And obviously you would only go as far as we could see with McGill's forceps. Perfect. No problems. So suction, tell me about the types of catheters. I know I've got one over here, but I can't see. There's one kind. I'll go. See if I can dig through the box.
So we have the soft tip and a firm suction.
Yes.
Which we use with the patients on the suction device.
Unfortunately, I don't think we've got a hard tip one. So tell me about when you would use the different kinds of suction.
So it depends on the size and age of the patient. So we're looking to use a soft tip with a paediatric patient. I could also consider that with a geriatric patient as well, given the tissue deterioration as we age, so as to avoid causing trauma. In a patient where there was more fluid, including the airway, I'd look at using a firmer tip.
Yeah. So that the Janker's suction unit. What are the key things you must be careful of when you're suctioning in terms of how far you suction? You mentioned about only suctioning for 10 seconds.
Yeah, so only as far as you can actually visually see. So you're not going to be looking at putting it any further down into the airway. No more than 10 seconds at a time with a review. And also ensure that you're suctioning using the appropriate pressure, and that's logged within the patient report.
So with regards to the pressure, what pressure should we use? Is there a specific value, or do you know that one?
No, I don't know that one.
So basically suction as much as you need
Yeah.
to get it out. So what I always recommend is start low and then work up.
Yeah.
So that's the only thing I would say about that.
Okay.
Okay. 2 seconds.